Sorry for the delay. My name is Janet Rodriguez. I'm a registered nurse, diabetes educator from the University of South Florida. And I am proud volunteer member of the ADA Safe at School Committee. And it is on their behalf that I'm pleased to be with you today to present the ADA's Diabetes Medical Management Plan, or DMMP. Next slide, please. This session is being recorded by the American Diabetes Association and will be made available online for public access and viewing. Next slide, please. While the ADA attempts to ensure that all information is accurate and current, this general information is not a substitute for individualized medical, legal, or other expert advice and assistance. The ADA, its staff, and volunteers do not provide legal or medical advice. For detailed legal advice or representation, contact and consult an independent attorney, and for healthcare consultation and advice, consult your professional healthcare provider. Next slide, please. Safe at School is pleased to offer its 2025 edition of the Diabetes Medical Management Plan for use by families, school, and pediatric diabetes healthcare providers nationwide. Its guiding principles are that it's contemporary with current therapies, technologies, and best practices. It's collaborative, recognizing and including the important participation of school nurses, students, and parents in the management plan, always facilitating communication between parties, and it's comprehensive in scope and outcomes focused. Next slide, please. Some of the changes in this year's DMMP include a simplified and clear description of required supervision at school, including remote monitoring by school nursing or trained staff when medically necessary. Additional space to document diabetes medications and new technologies. Enhanced hypoglycemia guidance for students using AIDs or automated insulin delivery systems. Enhanced guidance for young children, and added consideration for level of hypoglycemia and trending arrows when making treatment decisions. And finally, a reduced burden in completing the forms. A shorter form reduced to 5 pages. The orders are time-based, reducing duplication of entries, and a new comprehensive dosing fields that address carb counting, fixed dosing, and even meal estimations. Next slide, please. The DMMP is available right now at diabetes.org/DMMP. The document is a fillable PDM form, making it easy to complete and send via email or upload to schools and healthcare providers. The DMMP offers a comprehensive and detailed plan to start the year with a single dosing page update that can be used throughout the year to convey dosing changes quickly with minimal documentation. Next slide, please. Now let's review the DMMP by sections. Next slide, please. The information presented in this demo is fictitious. The first page includes a student's identification, name, birth date, and photograph. The name and date of birth will auto-populate on all of the other pages of the form, facilitating completion of the form and proper identification of the student in a busy clinic. The table of contents provides a valuable quick reference to locate important information in the document. It is color-coded to show parent and guardian sections in red and healthcare provider sections in black. This section also shows important school contact information. Next slide, please. Section 1, highlighted in red as a parent section, includes additional information about the student, such as their cell phone number and date of diagnosis. It documents modes of transportation, meals and snacking at school, physical activity, and the times of those events. These details are not always available the first day of school, but are very important considerations when interpreting glucose control and planning preventative measures for physical activity, dismissal, after-school sports, and other important events at school. Next slide, please. Section 2, also a parent section highlighted in red, provides valuable information for families to plan and gather the items needed at school to implement the school plan. Examples of must-haves at school include injectable rapid-acting insulin for students wearing insulin pumps, blood glucose meters for students wearing continuous glucose monitors, treatment for hypoglycemia, including glucagon for students using insulin, ketone strips, charging cords, batteries, all of these things that keep their devices running and their phones running. Being prepared will ensure that any minor disruption can be quickly resolved with minimal interruptions for the students and families. On the bottom of the first page will be the healthcare provider's name and clinic contact information. Once completed, it will auto-populate this important information onto each page of the DMMP. Next slide, please. Section 3, previously listed as students' self-management skills, is now clearly requesting a level of school nursing care and supervision. It is important that all students living with diabetes complete the DMMP, even when fully independent in care. Advancements to independent with diabetes care are not always in keeping with a student's age or grade, and progression to independence is not always linear. Proper evaluation of the student's ability to provide self-care will assist school staff in providing age-appropriate support and supervision for all students. The student and family of independent students should be introduced to nursing staff and instructed how to access assistance if needed. The presence of a DMMP will ensure that school nurses will have the information they need should the student request or require assistance. This section also describes the use of smartphones and if they are medically necessary. We now have insulin pumps and sensors that are fully operated via smartphones. Next slide, please. Section 4 describes glucose monitoring at school. Notice that glucose monitoring for meal times and with physical complaints or illness are listed as defaults. Since Christian, our sample student on the form, is self-care in this area, it is his responsibility to check his sensor when indicated and demonstrate proper attention to glucose alarms and readings, including when to report abnormal values. The orders show Christian is wearing a Dexcom G7 sensor. There is now a way to request remote monitoring by a school nurse or trained school personnel for medically at-risk students. You can see that in Christian's case, it is neither recommended nor medically necessary. These new options will facilitate appropriate level of monitoring for students at high risk for serious glucose events that need close monitoring and prompt medical attention, especially in students unable to communicate sensor alarms or symptoms, or with recent history or repeated serious glycemic events. There is also important guidance for the BG meter testing when it's required for sensor users. Section 5 describes all applicable insulin delivery methods, including the new option to document open-sourced or OS-AID systems. Formerly called DIY, the ADA considers these systems safe and effective and promotes support for people utilizing these systems. The DMMP includes new areas to document apps and other technologies for insulin delivery, dose calculations, and carb counting. Next slide, please. Section 6 specifies the name and categories of insulin used, also for documentation of field trip or pump failure dosing, as well as added space for other glucose-lowering medications. In our example, Christian is using ultra-rapid insulin, a long-acting insulin in the event of pump failure, and metformin with breakfast and dinner. The addition of evening and emergency dosing makes it possible to care for Christian during extended field trips, emergencies, and disasters. Next slide, please. Section 7, insulin timing relative to meals, has an enormous impact on after-meal glucose responses. Here we present the options with suggestions for their use. We noted on the previous page that Christian is using an ultra-rapid insulin in his pump. As indicated above, his timing is to give insulin at the time of the meal instead of early. Picky eating and food refusal can place a student at risk for hypoglycemia if they do not complete their meal or refuse to eat. Strategies such as dividing the doses when on a pump by offering correction prior to the meal can help get insulin into the body that will help slow down the meal rise. Giving insulin as soon as possible following the meal when on injections are important modifications made to maintain safety. Students using AIDs systems can have problems with late bolusing because in the absence of a bolus, the algorithms will immediately start giving extra insulin when it sees the glucose rising quickly, soon after meal begins. AID guidance recommends to skip entering carbohydrates once the bolus is 30 minutes or more late, instead suggesting corrections for the glucose elevations. It is important to understand how AIDs work. This section also reminds us to base correction doses on pre-meal glucose levels when delivering insulin following a meal with MDI. The last but not least section is May Advance. Allows the nurse to advance a student to pre-meal dosing once they demonstrate consistent eating patterns, ability to consume alternate foods, or ability to communicate when they have not completed a meal. Page 3 and section 8 is the dosing table that can be used as a one-page dosing update during the year. At the top, we first see the definition of a meal dose, which includes carbohydrate for food and a correction dose. Please note, always refer to the written orders when calculating a manual dose and not a pump setting. For example, when concentrated insulins are used off-label in an insulin pump such as Humalog U200, the pump settings will not reflect accurate dosing. Always refer to the paper version. Christian in this example is using a carb ratio or formulas to dose his meals. The formula is located directly underneath the carb ratio heading. He has 2 time blocks, and his carb ratio at 10:30 a.m. switches from 8 to 11. The third column is dedicated to fixed meal or carbohydrate amounts. It also allows for small, medium, and large dosing for each meal, as these alternate methods may be utilized on devices such as the iLet or the InPen. When not in use, there are many not applicable boxes for clarity. The final column on the right describes use of the bolus calculator and reminders to check ketones with hyperglycemia prior to administering insulin. This section also permits bolus adjustments for physical activity by the school nurse when designated so. And also parents that are involved with dosing management and adjustments can also be authorized here to make changes as well. Next page. The second table on page 3, the correction dose, is located on the bottom of the page. An important bit of information for this section is in red above the table. It describes how often correction insulin can be given, which in this case is every 3 hours. If Christian has an early lunch at 10:30, he would be eligible for a correction at 1:30, assuming he hasn't eaten or bolused again since lunch. It also reminds you that you cannot offer correction via an eyelet pump, as this is fully automated and not possible to request via the pump. Here again, the entries will be time-based. The correction formula is available in the second column with the formula in full display. The target glucose and correction factors are described below them for use in the formulas. The final column is a sliding scale that when used will provide a range of glucose readings with a corresponding correction dose. If correction formulas are used, not applicable should be selected for this section. A provider signature line is available on this page if it will be used as a one-page dosing update. Next slide, please. Section 9 is related to hypoglycemia management. It begins with common symptoms, which include poor attention, cognitive function, and concentration that, if occurring frequently, can interrupt a student's ability to succeed at school. This section includes symptoms of severe hypoglycemia, which is a medical emergency requiring glucagon. The treatment threshold suggests when to treat and includes exercise parameters allowing treatments at higher glucose readings. Treatment amount describes how many carbohydrates constitute one treatment. The default suggestion is for 15 grams, and approximately half of that, or 8 grams, for young children and students using AID systems. Instructions are provided for retreatment with carbohydrates if by finger stick the glucose level remains below 70, 15 minutes following treatment. Here too, there is an allowance to adjust the amount of carbohydrate used to treat hypoglycemia in order to achieve glucose targets following treatment. Avoiding overtreatment of lows is a primary goal for students using AIDs to avoid additional insulin delivery when glucose levels exceed the targets. It is very important in the management of these devices and will avoid repeating the hypoglycemia when used well. The goal is to treat to target. Next slide, please. When selected, this brand new section directs you to utilize CGM trending arrows and level of hypoglycemia to adjust the recommended dose of carbohydrates. Importantly, it allows you to increase the amount used in the event the glucose level is serious or level 2 hypoglycemia range. On the left, you are provided with the interpretation of the arrows you will see on each device. Notice that all of the arrows are not created equally. They are categorized into steady and slow, or fast and very fast drops. Find the student's device and arrow interpretation in this table. On the right, we see 4 categories. First being the presence of symptoms in someone that is not using a sensor, or an impending low alarm. Level 1 hypoglycemia is considered mild. Level 2 hypoglycemia is considered more serious. And finally, severe or level 3 hypoglycemia, where the student is unable to assist themselves, requires glucagon administration. And right on the chart, you will see the corresponding glucose levels for each level of hypoglycemia. In the example provided on the DMNP, the student has a level 1 glucose hypoglycemia level of 60 milligrams per deciliter, accompanied by double arrows trending down on a Dexcom, which is considered a very rapid drop. The table advises doubling the treatment, since we know that in 10 minutes approximately, the glucose level is predicted to be about 30 milligrams per deciliter, dangerously low. And this is a much more serious scenario than a student that's slowly dropping with a diagonal arrow down at 60 milligrams per deciliter, where only one treatment is needed. Next slide, please. This section explains why AID systems and their ability to suspend insulin well in advance of low readings requires less carbohydrates to treat lows, and how excess treatment can cause extra insulin delivery and repeat hypoglycemia. Again, we've revisited this idea multiple times now in this presentation. The idea that we really want to work in harmony with these AID systems so that they're not responding to excessive or uncovered carbohydrates. It then describes the proper choice of food and drink to use to treat level 1 and level 2 hypoglycemia using simple carbohydrates and avoiding fat, proteins, and fiber. It describes the administration of glucagon used to treat severe level 3 hypoglycemia and the type of glucagon available to the student. Christian, in this example, has nasal glucagon or Baqsimi ordered. Next slide, please. This final hypoglycemia section describes device-specific features designed to reduce insulin in order to facilitate exercise. These features reduce basal insulin, automatic corrections, and most AIDs set a new target of approximately 150 milligrams per deciliter. It is important to know that they require time to work in advance of the physical activity. When turned on at the last minute, an additional snack may be required to assist the student during the beginning minutes of exercise. Students use tubed pumps are encouraged to disconnect from the pump and suspend their pumps when participating in very physical sport where they can injure themselves with the pump, where the pump interferes with their ability to participate, or the pump is at risk of dropping or breaking. Always provide a place to store the pump in a clean environment, protected from extreme heat or cold. And finally, a reminder that students living with diabetes need access to water, bathroom privileges, treatment for lows, glucose testing on demand. Next slide, please. Section 10 reviews hyperglycemia management. It begins describing common symptoms and how it can directly interfere with concentration, recall of information at school. If occurring frequently, can have a direct impact on the student's ability to perform to their ability at school. It also describes symptoms associated with ketones that would prompt you to test for them, such as abdominal discomfort, pain, nausea, vomiting, fruity breath, or altered level of consciousness. It describes the treatment thresholds and principles of treatment, such as when to check for ketones, especially for students wearing pumps. The presence of moderate or large ketones describes the need for intervention and further investigation and suspicion of the pump. When hyperglycemia has found or trace ketones, it may be reasonable to attempt correction through the pump. When moderate or large ketones are present, correction insulin should always be administered via injection, following the orders, of course, as written. Equally important is to provide hydration, ensuring intake every half hour until the ketones are cleared. If on an insulin pump, arrangements should be made to change the infusion set and to resume insulin therapy as soon as possible, unless you're on an iLet. When injections are given, automated features are often turned off for 3 hours to avoid excessive insulin delivery through automation. Next slide, please. And finally, we come to the signature page. It begins with a request to send records to the healthcare provider if there are frequent excursions in the glucose levels more than 3 times per week. There's an area for the licensed healthcare provider to sign the orders, for parents to review and acknowledge the orders, give permission for treatment and communication and collaboration between the members of the student's healthcare team, and school nurses, a place for school nurses to review and acknowledge the orders. Next slide, please. Thank you so much for your time today. I'd like to look into the chat now to see if we have any questions or comments. Oh, so many. Okay, let's see here. Please tell me this has been sent out to all local pediatricians and endocrinologists. Crystal, I don't know if you have, if you'd like to respond to that question, if you're still there.
Thanks, Janet. Yes, I actually responded that we have widely promoted the DMMP to the provider and school nurse communities. So we're
Thank
always
you so
looking for
much.
ways to get the word out.
Thank you so much.
Thank you.
For the non-regular nurses, can we have a demo for diabetes management using the insulin to carb ratios? So again, Crystal, I don't know if this resource is available or if this is something that we can add as an addendum that explains how to calculate doses.
Yeah, there in our training modules, there's that can be found on our website. There's information on how to calculate insulin to carb ratios, and with the consideration of any correction factors. I'll put that link in the chat.
And you will be excited to know that we are developing resources that are device specific. Our hope is that these are resources that can be added as an addenda to, without requiring orders of any kind, resources that will explain each device's screen, what you're looking at, where to find histories, what the most common alarms are. So we're very excited to be adding that to our to-do list for the Safe at School Committee. Section 3 has definitions for level of support. In Section 4, how does the form define recommended for CGM and medically necessary? So those two terms are associated with a request for direct or remote monitoring by school staff. This is completely a medical decision that would be based on medical necessity by the provider. We do not provide a definition for that. What would remote monitoring of the CGM be by the school nurse look like day to day? So that is a very important question. I know that it is in practice by many nurses, and I know that we have had we want to support the nurses that are doing that currently. Crystal, do we have any work related to this topic?
We do. Our CGM guidance, which I'll put the link in for that, and that's about to be updated. So there's guidance provided by our Safe at School working group on that topic.
Good question. If Section 4 does not indicate any remote monitoring boxes, does that imply that we do not follow on the app? Yes, that's exactly what that means. So I think that the majority of patients will not require remote monitoring, but that's exactly what that means, that nothing would be selected in that area if the student does not require that level of support. With so many words on each page, is it possible for the provider to fill out the details in another color ink? I don't know. It is a digital form. I suppose that is probably possible. But I don't know the answer to that question. We have a question here related to the recommended supplies for school. I can't remember if this is in the guidance documents. This nurse types her own list to give to parents, but would love to provide something showing the ADA recommendations. I will make myself a note to see if there's a document already created by the ADA regarding this topic. But that's why we included the list to at least initiate that conversation on the DMMP. So we do have it directly on the form. Does this new DMMP tell you anywhere when to contact parents, i.e. low before or low below 55 or high above 350? I do not believe that that's in the document. So that would be something important to establish with the parents what their expectations are for being called. We did have it previously, but it's, Crystal, we don't have it on the form anymore, I don't believe.
No, I believe the thought was that that would be a decision that would be made by the parent and the school nurse.
Yes, yes. That's an interesting question. Just to clarify, on Section 4 CGM monitoring, if a student has been identified as independent, remote monitoring by the nurse should then not be recommended or medically necessary. I'm not certain that that's a given. I think that a student at any age could find themselves in a difficult medical situation that may require support, even if they're not. I don't, and this is completely my opinion. I don't think that being medically fragile has to correspond with full support, if that makes sense. But it's an important question and something that we'll talk about further. I have a question here about a 4-year-old going to TK this fall. Would it be advisable to say something like changes per parent? There is a designated section that very specifically describes parent involvement with dosing. So that's a conversation you would have with your provider, the person writing the orders, to establish what the guidelines are for dosing.
Janet, we need to take maybe one more question and then conclude.
Because low treatment is based on weight in this new DMMP, where would the weight be listed? Oh, I see what your question is related to the young child. Good question. It is not present on the form. So I do think that there's a correlation between size and weight. And remember that the most important part is that ability to notice and to pay attention to the outcomes of treatments for lows. If treatment in a child that seems young is causing hyperglycemia following treatment, then that's where we know that we're over treating. Everything that's suggested is a starting point, and not everyone is going to do well on those starting points. So I think the most important takeaway related to dosing, amount of carbohydrate for treatment, is to notice what happens 30 minutes later and to make sure that we're not blowing them through their target glucose or their exercise goals. Thank you so much for your time today. It was a pleasure. And I hope that the new form assists you. Thank you so much for the work that you do and for caring for kids with diabetes.